Hepatitis D is increasingly considered the most aggressive hepatitis virus. Can you tell us about the demographics of people affected?
HDV is a defective virus that needs the helper function of HBV for its productive infections to cause liver damage. Thus, the epidemiology of HDV mirrors that of HBV, and it is strongly influenced by timing and coverage of HBV vaccination. However, the great geographical variation of HDV prevalence indicates that additional factors influence the HDV circulation, such as transmission routes, hygienic and socioeconomic conditions, and migration flows. In Eastern Europe, there are endemic pockets, such as Moldova, where HDV prevalence is high among all S-positive individuals, whereas in Northern and Western Europe, HDV endemicity is low and affects mainly high-risk groups, including immigrants from highly endemic regions, PIWID, HIV-infected individuals, men who have sex with men, hemodialyzed patients, and anti-HCV positive individuals. In this setting, HDV prevalence varies according to anti-HBV vaccination coverage.
What is the burden of hepatitis D on those affected and, more broadly, on the healthcare systems treating those patients?
HDV infection is usually associated with an aggressive form of chronic hepatitis that progresses to cirrhosis and its end-stage complications, decompensation, and hepatocellular carcinoma in a higher proportion of cases in a short period of time as compared to chronic hepatitis B and chronic hepatitis C. The rapid and severe outcome of chronic hepatitis Delta in many patients results also from the fact that until recently the only available treatment was interferon alpha that show a modest efficacy, and it is contraindicated in patients with more advanced disease. In the last 2 years, bulevirtide, a new promising drug that blocks the entry of the virus into the hepatocytes, received a conditional approval by EMA. But unluckily, bulevirtide is not available in all European countries. Thus, liver transplantation represented and remains the only therapeutic option for many young chronic hepatitis D patients with terminal liver disease.
Hepatitis presents a major global and European burden. Considering the efforts towards hepatitis B and C elimination, which strategies would best be deployed against hepatitis D?
We have to consider 2 important levels of intervention to control HDV infection. Firstly, the primary prevention by anti-HBV vaccination. Since HBV is mandatory for HDV infection, the newborn infant anti-HBV vaccination is crucial to limit HDV circulation also. In addition, the vaccination of individuals at high risk of HBV infection can contribute to fight the HBV spread. At second level, we have the early identification of HBV-infected individuals to warrant a timely and adequate counseling and linkage to care. This goal can be achieved only by the screening of all HBsAg individuals as recommended by the recently released EASL guideline on HDV.
What is the status of hepatitis D elimination globally, and what challenges do we still face?
In terms of elimination, though, WHO has not set explicit goals, or the World Health Assembly has not endorsed goals for hepatitis Delta elimination like it has for hepatitis B and hepatitis C. We just don't have the same public health tools for testing and treatment of hepatitis Delta to make elimination possible like we do for hepatitis B and hepatitis C. But in terms of measuring progress of hepatitis Delta elimination, a key barrier is not knowing our starting point. As Dr. Booty pointed out on the webinar, most countries have not conducted robust national surveys on the prevalence of hepatitis Delta. It's also important to remember, though, that prevention of hepatitis B is also prevention of hepatitis Delta. And we do have good tools for prevention of hepatitis B and hepatitis Delta with child and adult vaccination. Vaccine rates are quite high in most parts of the world, but the greatest gap is around hepatitis B birth dose vaccination in the African region. In And then in terms of hepatitis delta testing and treatment, on the webinar, Dr. Zulin provided a very nice overview on the challenges with current hepatitis delta diagnostics and areas of research, while Dr. Wedemeyer described how hepatitis delta treatment still requires a personalized management approach for individual patients. The hope is that the science will continue to advance to make testing and treatment simpler and easier to scale for public health programs globally.
What are national hepatitis elimination profiles? What do they assess, and how can they help towards the elimination goal?
So the National Hepatitis Elimination Profile Initiative was launched in 2020 by the Coalition to provide a unique resource to assess the status of what we call the essential components of hepatitis elimination, the policies that lay the foundation for scaling up hepatitis B and C prevention, testing, and treatment at a national level. The profiles not only show whether a policy is in place or not, but also provide qualitative information on the most recent achievements, challenges, and innovations around this policy. Profiles are all developed in collaboration with government, clinicians, and civil society. And on the topic of hepatitis delta, we have started to incorporate some prevalence information and testing and treatment guideline information related to delta, but this is still an area of development as the information is so sparse, as we talked about earlier. And for the European region, we have recently released updated profiles for Spain, Portugal, and Switzerland. We've also developed profiles for Italy and Georgia that are available as well. And I'm thrilled to share that for World Hepatitis Day, we'll be releasing a profile for Ukraine. We hope to develop more profiles, though, so if you're interested in developing one for your country, please reach out to us.
How can lessons learned about hepatitis C elimination be applied to hepatitis D?
So from hepatitis C elimination, we have quickly implemented lessons learned from other disease control and elimination initiatives, such as the need to reduce treatment prices and remove restrictions to treatment. However, most countries have not moved as quickly to scale up screening initiatives. One of the key learnings is that treatment accessibility is critical, but not sufficient to reach elimination goals when such a large proportion of those living with hepatitis C are unaware of their infection. So in addition to treatment costs coming down, screening costs also must be reduced. And in many countries, we're seeing that PCR testing is actually the true affordability barrier now. As treatment costs have declined, PCR testing has not declined at the same rates. So when we look towards hepatitis D testing, hopefully we'll learn that lesson as well in the future, that testing costs and testing accessibility is just as important as treatment. So with that, I would like to thank EASL for the opportunity to celebrate World Hepatitis Day collaboratively. In the Coalition, we look forward to working with you to advance hepatitis elimination efforts. You can reach us at globalhep@taskforce.org. Take care.